All right. Thanks y'all for being here. We are very excited for today's Emory Department of Medicine Grand Rounds featuring our very own Dr. Gundlapalli, who is a senior physician scientist with training and expertise in the fields of immunology, infectious diseases, and informatics. He received his medical degree from the Madras Medical College in India, and he received further training at the University of Connecticut Health Center, where he earned a PhD in immunology and completed his internal medicine residency. In Utah, he completed a 3-year clinical and research fellowship in infectious diseases at the University of Utah School of Medicine and a master's degree in biomedical informatics. As a background for this presentation, he sees patients with primary and secondary immune deficiencies here at Emory and has done so since December of 2023 and is an adjunct professor of medicine at Emory University. Previously, he practiced clinical immunology and infectious diseases in Salt Lake City at the University of Utah School of Medicine from 2006 to 2019, where he was a tenured professor in the Department of Medicine and a staff physician at the VA Salt Lake Healthcare System. Along with his clinical practice, he was a medical director of diagnostic immunology in Salt Lake City, where he worked on the performance and interpretation of diagnostic immunology tests. With over 200 peer-reviewed publications, he has received numerous awards in recognition for both his clinical and academic work, including the Excellence in Patient Care Award from Emory Healthcare in 2025 and the Global Clarivet Highly Cited Researcher Award for 2025 in the Crossfield category. Thank you very much for being here, Dr. Gundlapalli.
Thank you. Good afternoon, everyone. Let me start off. Um, are you able to see my slides? Perfect. Thank you. Well, thank you, and good afternoon, everyone. It's a pleasure and honor to visit with you at Grand Rounds today on a topic that's very near and dear to my heart. I wanted to thank the committee, Dr. Massert, for the invitation and the opportunity to share my experience in the field of clinical immunology. Trying to move the slides. So there you go. Okay. I think it went too far. So first of all, no financial disclosures, no conflicts of interest. I'm currently a full-time employee of a consulting and contracting firm called Active Resources that works almost exclusively with the federal government and the Veterans Health Administration to provide strategic communications, EHR modernization consulting, and also clinical staffing. I did use commercially available AI platforms to assist with some background research and graphic design for this presentation, and I've all independently verified and reviewed those outputs for hallucination and exaggeration. There will be some mention of off-label medication use that I'll get to later on in the presentation. The objectives are fairly straightforward. Outline the clinical and laboratory evaluation of an adult patient with suspected non-HIV immune deficiency. Discuss the presentation and management of patients with common variable immune deficiency, or CVID, which is a prototype of primary humoral immune deficiency that we see in adults. And lastly, I want to increase awareness of secondary or acquired hypogammaglobulinemia in adult patients undergoing B-cell depleting therapies. So let's start with some clinical vignettes, as we usually do for grand rounds. The first is a male with a history of recurrent sinus and lung infection. So we're looking at 6 to 8 sinus infections per year, 2 to 3 bronchitis episodes, and at least 1 pneumonia every year or every other year. And this has been going on for several years, going from provider to provider, and lots of antibiotic courses over the past 12 months, 24 months. Second is a patient who's a female with interstitial lung disease and has been managing somewhat, but has been slowly going down over the past year or so. And when their providers checked, her immunoglobulin levels were low, specifically IgG. So this is a case where patients present with something other than immune deficiency or an infection right off the bat, where the manifestation of the immune deficiency may come first. And I've seen that over the years. The third is a young woman who has an autoimmune disease and is being treated with B-cell depleting therapy. and she's not been well for the past 6 months to a year, with at least a couple of hospitalizations for pneumonia, as you can see here. Just by the way, this graphic was created by AI based on just my prompts, so it did need some editing to do, but I was quite impressed with how it created the graphic. The usual complaints that we see in our clinic are myriad, and you're familiar with these. So the patients are struggling. They say something is wrong with me. My immune system is weak. I'm frustrated. I always catch what's going always on antibiotics. I'm always tired, and I catch every infection there is. And you've seen that, I think, in your own practices also. The clinical immunology service, patients are referred usually by their primary care providers or specialists. I'm very fortunate to have worked with almost every specialty here at Emory in the past 2.5 years: pulmonary, rheumatology, hem-onc, ENT, GI, neurology, and infectious diseases. Mostly outpatient referrals, and we do get some calls from our colleagues in hospital medicine when patients are admitted with severe infections. Occasionally, the patients come as family members of existing patients. There are a few who are self-referred, and then, of course, the worried well also will see in our clinic. And the presentation is usually with a history of infections. Sometimes they do come with autoimmune or inflammatory conditions, as we discussed in the vignette. And then nowadays, the increasing number of referrals for secondary immune deficiencies, primarily secondary hypogammaglobulinemia in patients with infections. I want to start with a very brief overview of the human immune defense system. As you can see here, just a very simplistic view of looking at it at stage 1, stage 2, stage 3. Stage 1 is really the external and internal barriers. And as you all know, the skin is a great organ for this. The innate immune system is a primitive immune system that goes all the way back through evolution. It doesn't think, it just acts. So these are the natural killer cells and many of our white cells. The complement system is literally a group of proteins that complement the rest of the immune system and also are part of the innate immune system. What we'll be discussing mostly today is about the adaptive immune system, which is an exquisitely coordinated and orchestrated response to every single pathogen and microbe that we see. And we see those every single second, every single minute through the air, through our skin, through the gut, etc. And as you know, the T and B cells interact with antigen presenting cells that present the antigens, and the T cell take those antigens, provide signals through helper T cells to the B cells, and then B cells do their bidding to make antibodies. We make IgM or primary first. That's the pentamer shown there. And then within a few weeks to a few months, we switch to IgG. IgM is often thought of short-lived for a few weeks, but we've seen over the years that some infections have persistent IgM for months, if not longer. Example, West Nile virus is one of those. So IgG is the long-lived antibody, the most abundant in the blood, and really is our effector molecule for fighting infections. IgA is an amazing antibody. It's by quantum, it's the most by volume in the blood. I mean, in the body. It's secreted into the blood, of course, and then translocated to the mucous membranes and does amazing work locally all along there. IgE, as you all know, is associated with allergies and parasitic infections, and very rarely in syndromes such as hyper IgE syndrome, used to be called also Job syndrome. IgD is an antibody that's present on the surface of B cells. Very little is secreted into the blood. And by the way, we never measure. There's no commercial assays, nor is there any need to measure IgD in the blood. So we'll be talking a lot about IgG in the next few slides. Switching to how do these patients come and what are the flags for HIV immune deficiency in adults. Really, we'll be talking a lot about bacterial infections, and those are very much correlated with humoral immune deficiency, which is really the most common that we see in adults in the immunology service. So, recurrent sinopulmonary infections are the hallmark, like the first patient in the vignette, especially with encapsulated bacteria like Streptococcus pneumoniae. Haemophilus influenzae. You would think we've conquered Haemophilus influenzae, and then last year, one of the patients was referred to me from inpatient who had come in with Haemophilus influenzae bacteremia and sepsis. So it still happens. Then patients with severe, frequent, and recurrent infections. And these are sometimes difficult to quantify or characterize, but really there have been some attempts in the literature to talk about what is frequent, recurrent, serious, etc. So generally, this more or less accepted, but always very much along with the clinical condition. When you have four or more infections requiring antibiotics within 1 year, that we would consider quite frequent and recurrent. The hallmark, as I said, were sinusitis, bronchitis, pneumonias, otitis media with perforation in adults, usually not common at all, so something to think about. Interestingly, urinary tract infections have not been directly associated with systemic immune deficiencies. So even though we ask about them, that's not usually a flag. Um, Two or more radiologically proven pneumonias within 3 years is quite significant. As you know, it's not easy to prove those radiologically all the time, but we have to try our best to get to those. And then two or more severe bacterial infections, so sepsis, meningitis, septicemia, cellulitis, osteomyelitis, or septic arthritis also. Another one that we've seen over the years, clinical experience, is really recurring infections requiring prolonged antibiotic therapy and or IV antibiotic therapy. Viral infections are seen in patients with humoral immune deficiencies. There's a classic persistent norovirus infection that we see in CVID and hypergam patients, which are very difficult to manage. Um, Patients with COVID who've had severe outcomes. So it's obviously not all patients with severe outcomes in COVID have humoral immune deficiency, but those with humoral immune deficiency end up having severe outcomes in COVID. There is a highlight of, and probably a board question about Giardia duodenalis, previously also referred to as Lamblia, where you get those parasitic infections in CVID patients. So I always ask about those, and it flags maybe about once in 4 or 5 years or so once. Fungal infections are actually rare in pure antibody deficiency syndrome. So if you have recurrent fungal infections or severe, then we should look beyond just antibody deficiency into combined T and B cell immune deficiencies and definitely innate immune deficiencies. Over the years, there are also patients who've had recurrent, prolonged, and unexplained fevers. So FUO workup at some point should also include some screening for immune deficiency. By the way, I have kept all the references at the bottom of each slide, and I'm sure when you see this later, you'll be able to access those. Now, rarely seen in adults, these conditions have an onset in the pediatric age group, and we do see adult survivors. So, talking about adaptive T cell immune deficiency, T cell Th17 immune deficiency that causes mucocutaneous candidiasis, combined immunodeficiency, T and B cell, where you look at severe combined deficiency or SCID patients. The most common are X-linked and ADA or adenosine deaminase deficiency. Scott-Aldrich syndrome, which is X-linked. Innate deficiencies such as chronic granulomatous disease, which are phagocytic defect. And then terminal complement deficiencies. That's a board question at all levels, internal medicine, infectious diseases, about recurrent Neisseria meningitis. That actually, in my practice at Utah and now even in Georgia, I've been very fortunate. We do have, except for the mucocutaneous candidiasis patients, I actually survivors of these severe pediatric age onset group who are now in their 20s and 30s and thriving. So it's amazing to see how modern science medicine has brought about these changes. Even 10, 15 years ago, these were almost definitely terminal illnesses. All right. Evaluation. So no surprise here, detailed history, review of symptoms. I always ask, even in 60, 70-year-olds, a very general statement about their childhood. So were you a healthy child with usual illnesses or sickly child, missed a lot of school or in between? And that usually helps quite a bit in starting the discussion. Infections, we go very deep into what, where, when, and how many, and try to get a confirmation as much as possible. So, yes, I've had 3 pneumonias. Did they take an x-ray for each one? No. It was a walking pneumonia. So those are all important, I think, nuances to think about. Family history is important. We do have some families where the mother and then children have immune deficiency, but are not directly related to any particular gene variant. And so, and as I mentioned earlier, patients with autoimmune and immune dysregulation issues are also increasing in our practice. So, always asking about, have you ever been diagnosed with any issues with rheumatology, hematology, neutropenias, thyroid, those kinds of conditions? And of course, now I always have a section on the net state of immune suppression. Could be as simple as steroid short courses, which usually are not at all dampening the immune system, to long and prolonged courses of steroids, and then, of course, adding all the other immune modifiers and now B cell and plasma cell depleting therapies. So it's important to go into that. Physical examination, of course, routine, and then the majority of our evaluation is with laboratory. So I always do routinely a CBC and a CMP, which I think helps quite a bit, sed rate and a C-reactive protein. And then we turn to the immunology laboratory, which is a foundational partner for our evaluation, and such a great dialogue and help between the tests that we offer here at Emory. And there are several send out tests that are actually sent out to ARUP laboratories at the University of Utah in Salt Lake City, where I used to work also. So a huge shout out to our colleagues in the immunology laboratory for ever changing and evolving tests and offering the best possible for our patients here. And the laboratory evaluation follows how we look at the immune system. So, since the most common are humoral immune deficiencies with little smattering of involvement of T cells, I'll start with the cellular immune system and the humoral immune system. So, we always look at, do you have enough numbers of T and B cells to do the job? So, it's like the infrastructure layer. And there is actually a very nice profile that you can do. It's called T/B/NK, or natural killer cell profile. Gets you 3 types of T cells. CD3 is a pan T cell marker, CD4 helper T cells, CD8 cytotoxic T cells. B cells in this particular profile are CD19 marked on their surface and works very well. And then the natural killer cells are CD16 and 56. So usually the turnaround is less than a day, and we get a very nice readout of the actual numbers and also the percentages, and tells us even beyond what we do for HIV, as CD4, CD8 gets you a good idea of, is the infrastructure there and a bit of the innate immune system. There is a functional assay called lymphocyte antigen mitogen proliferation panel that actually takes the T cells, puts them in culture, exposes them to 2 different antigens, which are Candida and tetanus, and then 3 mitogen, which are actually chemicals, pokeweed mitogen, phytohemagglutinin, and concavalin A, and then sees if the T cells are able to incorporate tritiated thymidine and proliferate. So it's a good overall test to show, are your T cells are able to respond to specific stimuli. Now, sometimes the test is the results are difficult to interpret, and I'm always happy to help with those. And then, of course, the piece de resistance is our humoral immune system, where we're looking at encapsulated bacterial infections. We look at IgG levels, IgA, IgM, IgE also, just to be complete. IgG subclasses are available. I know some of you used those G1, G2, G3, G4. Over the years, I ordered them very rarely because it's very difficult to pinpoint and say, aha, this particular G subclass is a bit low and that's causing all your problems. And of course, we can't replace a specific subclass either. So sparingly I use it. Always work with our colleagues to see how best to use those. In older adults, especially in their 40s, 50s, 60s, etc., I do a serum protein electrophoresis with immunofixation to look for abnormal proteins, obviously paraproteins. So I think is a good baseline. We've picked up several patients with MGUS or monoclonal gammopathy of unknown significance. Then we work with our colleagues in HEMONC to monitor those patients. And then we do have functional assays for the humoral immune system. So we can look at antibody titers to specific vaccine antigens. So T cell dependent protein antigens that are diphtheria and tetanus. I order them almost every week. And then we can look at antibody titers to T cell independent polysaccharide antigens. So this was the classical pneumococcal Pneumovax 23, which is polysaccharide. The newer pneumococcal vaccines are conjugated, so they shift into the protein antigen one. It's difficult to get pneumococcal 23 or PCV23 nowadays, thanks to a lot of our colleagues here from ID and pharmacy. We stock that in our clinic, but we can't get it in any other pharmacy or primary care practices. So we just have to make do with what we have. And then, of course, we do pre and post vaccine responses, which are a really good test if you have time and the patient is not incredibly ill or sick. Then, if you wait a month or so, you can give a vaccine and see if they make responses to either pneumococcal and/or diphtheria and tetanus. And that helps us quite a bit in figuring out where the function of the immune system is. To round out the evaluation, about the innate immune system. The CBC tells you a lot right there with the differential. The natural killer cells number and percentage comes as part of the T, B, and K cell profile. Total complement CH50 is what I use as a screening test. It's extremely rare. In 20 years, I've never seen a patient with true complement deficiency in adulthood. So I only do the total complement, and very rarely do I have to do individual complement components. And of course, going to the alternative complement pathway is extremely rare also. There are functional assays which are rarely ordered in adults, but we do those when all other testing is negative. So you've done the T and B cell numbers, infrastructure, functional, and then you're looking at, boy, we still don't have an answer, then it is worth going to these rarer conditions. So the neutrophil oxidative burst assay, which our pediatricians have a lot of experience with, and our infectious disease colleagues, screening for chronic granulomatous disease, where you have aspergillus and nocardial infections. T cell toll-like receptor function, for unexplained invasive pyogenic infections. And then cytokine profiles looking for Th17 deficiencies and the interferon gamma IL-12 axis deficiencies in disseminated mycobacteria. We do see patients who are suspected to have mucocutaneous candidiasis, but in 20 years, I've not had a patient with confirmed diagnosis there. As I said, these are very rare to see in adults. Our pediatric colleagues order these very often. And then if they do find and they make it to adulthood, then we see those patients here. All right, I think we're doing okay. Genetic testing. So previously in the realm of research and referral testing, but I would say in the last maybe about 6 years, there are commercial entities offering genetic testing. Usually it's called the Inborn Errors of Immunity or the Primary Immunodeficiency Panel, and then the Cytopenia Panel if the patients also have comorbid cytopenias. In general, it's very low yield for adults diagnosed with primary immune deficiency. So I do offer that. We do end up testing. I think I've sent about 50 or 60 or so in the past 2, 3 years, but it's very low yield. And we'll talk about that when we look at CVID. Now, when you order any genetic testing, obviously, everyone has some variant of unknown significance or VUS, and that generates a lot of discussion. Usually, I have to look it up and find out what that gene is, and then talk to our colleagues in the genetics department to help think through whether are they significant for the patient or not. The cost of testing is not insignificant, so that has to be a consideration, and the low yield are also factors to consider in choosing when and who to send genetic testing for. All right, now the second objective, I want to spend a few minutes on common variable immune deficiency. So just splitting up the name, common, it is truly the most commonly seen primary immune deficiency in adults in our clinic, and happened in Utah and happened here in Georgia and definitely around the country. Variable because the etiology is variable, as are the presentations and manifestations. And that I've learned over the years about how nuanced that is. And of course, immune deficiency in this case refers to humoral immune deficiency. It's really a group of heterogeneous primary antibody failure syndromes characterized by hypogammaglobulinemia or low IgG. Two clinical phenotypes we see, infectious complications being the most common. There are actually a subset of patients that have non-infectious complications. You saw the autoimmunity, the inflammatory, lymphoproliferative patient with the ILD. I have seen one patient who presented with lymphoproliferation first. And of course, there's overlap of infectious phenotype with the autoimmunity. There is actually a consensus definition for CVID because it's not always easy to make that diagnosis. It's still sort of a constellation of features. So most patients will have at least one of infections, autoimmunity, or lymphoproliferations, many times two out of the three. Low IgG level, generally below 400, we'd consider quite significant or severe. Normal range in our lab is above 610, so all the way to 1600. So generally a lowish IgG. They also have low IgA and IgM. And then the key point is they have a demonstrable impairment of response to at least one type of antigen, the vaccine antigens we just talked about. We have to go deep into excluding causes for hypogammaglobulinemia. As I'd mentioned, we ask about steroid therapy, B cell and plasma depleting therapies. There's also rarely seen, but patients on long-term anti-epileptics actually have low IgG also. And of course, there's patients with malignancy, and very rarely we see excess loss of proteins or immunoglobulins from either the kidney or protein losing enteropathy. I think I've seen one patient over the years that had such malabsorption and protein losing enteropathy that they ended up having such low IgG levels that they needed replacement for a short period of time. The etiology, as we mentioned, is variable and heterogeneous. Ultimately, what happens is either you have decreased numbers of B cells, or there's a signaling problem along the immune cascade where antigen presenting cells aren't presenting properly to T cells, helper T cells, or the T cells aren't presenting to B cells. And there's abnormal signaling all along the cascade. So the end result is a decrease in IgG production, or even if you have normalish IgG levels, they're ineffective. They're not doing their job. And of course, immune dysregulation occurs and in infections also. There are molecular defects now shown to be directly associated with CID, but in adults, it's more likely to be polygenic and oligogenic. So 90% of adult onset CVID cases have no identifiable monogenic cause. Those who have are usually have onset early, below 18 years. They have strong family history and autoimmunity, lymphoproliferation, and when you do B cell phenotyping, they have low memory B cells. These are some of the most frequently implicated genes. So the TACI or the TNF RSF13B is probably the most common that I've seen among adults, where it's like a variant that they've seen, not always a pathogenic variant. An NF-kappa B pathway I've seen, and I have one patient family with that. And then more recently, we saw a patient who had a variant of unknown significance in CTLA4 and has a phenotype, behaves just like a CVAD patient. It is a true zebra, so the true prevalence is unknown. Estimates range from 1 in 25,000 to 1 in 50. And as I said, make the diagnosis can be challenging even with guidelines on this. And frequently the diagnosis is delayed. We've often heard of our patients going from provider to provider for years before someone's thought to check IgG levels and then referred them to us. So really an awareness and high index of suspicion is essential. Management of CVID. This is our highlight slide. The mainstay of management is IgG replacement therapy. So you can never completely reset the immune system. So it's literally just like renal replacement, it's IgG replacement therapy. So for many years now, we've had IV IG, and then for many, many years, even about 10 years or so, we've used subcutaneous IgG, which is a huge boon and benefit for many patients who have side effects from IVIG. And there's a whole talk we can give on the different types of those, but please know that there are many options for patients to get IVIG in infusion center, get IVIG at home safely, do subcutaneous IgG by themselves at home, which can also be a weekly or even monthly. The mechanism of preventive infection, it's actually quite straightforward. It's the ultimate passive immunization from donors. So you're giving, if the patient can't make antibodies to all the bacterial pathogens that we see as a community, the plasma donors are literally giving them ready-made antibodies to give. So it's the ultimate passive immunization from donors. There is some anti-inflammatory and immunomodulatory effects of IgG, but the doses that we use are not tremendous for anti-inflammatory. There is an effect, but not the way that neurologists and others use higher doses for rheumatologists use for anti-inflammatory effect. Now, important to note that patients do have low IgA, and some patients may have total IgA deficiency and low IgM or IgM deficiency, but we cannot replace IgA and IgM, and that's something it's very important to help communicate to the patient because they will see that their IgA and IgM continue to be low throughout the years that we follow them. There is a fair evidence base for this. It is an FDA-approved indication using IgG for primary immune deficiencies, and I've highlighted two sort of practice guidelines, which are very helpful, where the category is you wouldn't have the best A category here, but definitely B based on category 2 evidence or extrapolated from category 1 evidence. I think in today's world, it's very difficult to do a complete randomized placebo-controlled trial to see whether IgG replacement helps a patient with primary immune deficiency or not. It's probably not even ethical to try such a thing now. Treating and preventing infections is our other really huge important part. Antibiotics, of course, for acute infections, and this is very difficult, and I've struggled with this, but over the years we've found, and it's also in observational studies where patients need longer courses of antibiotics and or IV antibiotics. So whenever our colleagues are referring patients, I always talk to them, discuss, and see if we can help them because they relapse otherwise very quickly. Prophylactic antibiotic therapy has been a mainstay in clinical practice around the country and around the world. It's based on commonly seen pathogens and clinical experience with patients like with cystic fibrosis, COPD, bronchiectasis, and of course with HIV patients. And the practice for prophylactic antibiotic therapy varies across the country. So I only use narrow spectrum agents, and there are many who do rotating regimens. Now, there's always a benefit versus risk that you have to discuss: efficacy, tolerance, adverse events, and of course, the ever looming antimicrobial resistance. So try to use the most narrow spectrum that you can for the shortest duration, maybe just for a few months during the winter respiratory season, when you're getting them ready for IgG or their overlap with them, and then release the prophylaxis for the summer and fall, etc. And all that. You would be surprised, but it's actually quite limited published studies on whether antibiotics, prophylactic antibiotics, have been subjected to placebo-controlled trials. There's one Italian trial from 2019 that showed low-dose azithromycin was quite beneficial in patients with primary antibody deficiencies. There are several observational studies, but again, I think in today's world, every paper will start with, we need more evidence, but I don't think it's possible to do a true placebo-controlled randomized trial of antibiotics versus no antibiotics in a patient with primary antibody deficiencies or even secondary hypergammaglobulinemia nowadays. So we'll just have to make do with what the evidence is available. Um, Apart from infections and beyond infections, we've now known over the years that CVID is extremely complex. There is an inflammatory component, immune dysregulation component, and this is a great review from just a few years ago that put it into a very good picture format about almost every organ being affected. So we work closely with our pulmonary colleagues for an interstitial lung disease. There's a specific type called GL, or granulomatous lymphocytic ILD. There's granulomas, there's lymphoproliferation, and so almost every GI, and so we're working with colleagues in all our different specialties to help manage our patients here. Individualizing the dose of IgG replacement therapy. So we initiate for immune deficiency at a tight interval of, or rather range of 400 milligrams per kg to about 800 milligrams per kg. As you know, our colleagues in neurology, rheumatology will use much higher doses, 3, 4 times, 5 times those doses. The dosing that I'm used to and what FDA talks about is actual body weight in kgs, not the ideal body weight. I do feel that using ideal body weight does underdose some of the patients, and so we worked with our colleagues here to help with some of the dosing for those patients. We always individualize the dosing based on clinical condition, infections, energy level, and ability to work and engage socially. So as they get better, then we can get them stabilized. And then if they're doing very well after a year or two, we can even try to decrease the dose of therapy. Trough levels are a guide. We aim for about 6 to 700, which is sort of lower limit of normal. IVIG, almost all patients are on a 4-week schedule. So there's some that are on 3-week, but we try to get them all for 4-week because, they're doing this for years, if not life. And so even one less frequent IV is actually a huge benefit for them, for their quality of life. Subcutaneous IgG is an amazing product. There's several of those on the market. Patients can do those weekly. So you split the monthly dose into weekly. They can do it biweekly, every 2 weeks. And there's one product that you can actually do under the skin once a month. And patients love that too. So lots of freedom, lots of opportunities, lots of ways to change and help so the patient can get very comfortable and then do this for years on end. I have patients who've been on IgG therapy for 20 plus years, actually, and have been doing very well. Dosing and trough levels, actually, they have been really good. One seminal meta-analysis in 2020 by Dr. Jordan Orange and colleagues. There's also a meta-regression study in 2020 and 2 other prospective cohorts. And the bottom line is that, yes, if you have a higher IgG trough level, then there is definitely a correlation with decreased serious infection rates. So that's where I think, based on the clinical condition, we'd like to work with all of you to help with the IgG dosing. All that, of course, not go too high, but definitely do that. And then some patients, like those with bronchiectasis, require higher levels. Now, granted, all these studies and data are derived from studies on primary immune deficiency patients, but over the years, we've been able to, in the rest of the country, we've been extrapolating those to secondary hypogammaglobulinemia patients, and that's worked out very well over the past few years. The source of IgG, you'll all be, I think you all know this, but it is from human plasma donors. Even in 2026, it's not synthetic. I've been changing that number for the past 10 years, saying even in this year, it's not synthetic. It's plasma collected from several hundred individuals, end up making a bag that, for every month and every month usage there. They're tested for all known pathogens, viral inactivation procedures, addition of stabilizers. And it takes about, they say, about 10 months from the time persons donated the plasma to making it to our patient. So they do have antibodies nowadays for flu, influenza, and COVID, but they're sort of last year's antibodies. So you have to be cautious about that. They are protected, but not due to the most recent variants. One thing important for all our colleagues, especially our infectious disease colleagues, patients on IgG therapy will have infectious disease serologies that are positive. And so they're all coming from the hundreds of individuals who have donated. One of the ones I've seen quite a bit is it's not automatic, but varies batch to batch, but patients do come up with hepatitis B core antibody positive. And so patients, especially rheumatology patients on rituximab, where they monitor hep B core antibody afterwards for reactivation, but it's positive. And then we're able to help them think through that they were never positive and it's correlated with the IgG. So they don't have to be on hepatitis B suppression therapy and all that. So these are important sort of pearls for our colleagues to know about this. A few special situations before we move into secondary hypergam. IgG replacement is safe in pregnancy. We keep pace with the dosing with weight gain during pregnancy, usually increasing the dose by the second trimester also, monitoring the IgG levels. IV and subcutaneous routes are just fine, though patients who are using it by subcutaneous are very wary of injecting or transfusing right in the abdomen area as they're starting to show. Then they go to the sides and the flanks. And many patients have taught me how to do that as they've progressed through their pregnancy. Limited published literature, but fortunately a good clinical experience and written in the literature too about this. So at Utah, I had at least about 11 or 12 patients who went through successful pregnancies in a 15-year period. Here, already about 5 in 2.5 years. We close collaboration with maternal fetal medicine and peripartum complications. It is a high-risk pregnancy, and patients do end up getting, higher risk for infection around the time of delivery. So we have to be very cautious. Vaccines in general, patients on IgG therapy don't need any vaccines because they're receiving ready-made antibodies. The only two exceptions are annual influenza and annual COVID, with the rationale being even if they make some small amount of antibodies, then it may be to the new vaccine that the annual one brings out. Absolutely no live virus or live bacteria vaccines for immunodeficiency patients. And not clear. So ongoing discussion about do these patients on IgG therapy need RSV vaccine because that's fairly new. So the donor pool will not have antibodies to RSV for all adults. And recombinant zoster vaccine, not yet clear. And same thing with human papillomavirus vaccine. Primary immune deficiency in COVID, as I'd mentioned, poor health outcomes in patients with primary immune deficiencies in COVID. However, the vaccine is actually safe and quite good to give in those patients. This is from the U.S. Immune Deficiency Net registry here. Okay, now moving in the last few minutes, I'd like to talk about secondary hypogammaglobulinemia. So ultimately, either from decreased production from B cells due to either depletion or some disruption or increased loss of IgG proteins, you end up having patients that look and behave just like a primary immune deficiency where their IgG is not functioning well. Um, just a quick overview of B cell lineage, which is an amazing orchestration of how they go through from the progenitor, stem cells, progenitors through pro-B, pre-B, immature, naive, all the way to memory and plasmablast. And I thought I'd overlay the medications that we now see in healthcare. So the prototypical is rituximab, highlighted in the middle here, CD20 targeting. There are other agents now, ocrelizumab, ofatumumab, and ubli here. There's CD38 targeting, which goes to the plasmablasts and plasma cells. That's daratumumab and isatuximab. And then, of course, now the CAR T cell therapy, which has taken off. And please, I'll take help from our Hemonc colleagues to help pronounce the names of these agents. But the CD19 is a broad B cell lineage targeting. So now, and of course, the B cell maturation antigen targeting also occurs through T cell, and they're specifically for plasmablasts. So if you overlay this with where the IgG levels are, and really in the CD20 patients, anywhere from 15 to 40%. In CAR T cell therapies, because of their comorbidities, they're starting with low IgG and usually about 60%. You can see all the trials and the literature talks one or two lines in the results about, and so many patients were managed with IgG replacement therapy. And of course, the daratumumab patients also starting off with low IgG and then developing pretty significant hypergammaglobulinemia. The mechanism is depletion and eliminating the precursors of antibody secreting plasma cells. The challenge comes in if you have prolonged or continuous cycles of B cell depleting therapy. So it's not just one and done. Patients are on multiple cycles and combination immune suppression. So even though they don't show the IgG nadir for a few months, they end up having prolonged IgG depletion on that. And we really need to have a heightened awareness and looking for those patients and then prompt evaluation and prompt initiation of therapy. This is a slide. I know it's very busy. The intent was to be illustrative and not exhaustive, but shows you current FDA indications and the specialties that are using B cell and plasma cell depleting therapy. So not just hemonc and rheumatology as we think, neurology, multiple sclerosis patients, dermatology, we've seen in our own practice here, nephrology, transplant, and pulmonary. So you can see this is evolving and expanding. And so we only expect as these agents take off and there's efficacy for their primary diagnosis, be it in hemonc, neuro, rheum, or the specialties, then we will end up needing to help support those patients with IgG for a proportion of them. Rituximab was the prototypical, and so some of the earliest and most frequent publications are on that agent. And so there are risk factors. They're associated with infectious risk. Now it's been shown again and again through many studies, observational, to do that. And we can now extrapolate those findings to other B cell plasma depleting. So how do you screen and follow up patients on B cells? So there are limited national guidelines. So some of the guidelines are actually from Europe and other areas, not US. There's a huge variability in practice, just talking to our colleagues here at Emory and in Utah also. And there are recommendations to check pre and post treatment, at the very least, IgG levels and B cell subsets. And of course, pre-treatment Hep B, Hep C status, HIV vaccination status. And And we've seen, and this paper is just a very important one that came out many years ago, but highlights that many patients who've been on rituximab were not monitored for their IgG levels before and even after therapy on that. And that's been now replicated in many observational studies. So my suggestion and recommendation is to have increased awareness, and we're here to help. We're actually working with several of our colleagues here and our fellow, second year fellow in allergy and immunology, Dr. Kelly Cronin and Dr. Anyang Lee, to look at the prevalence of secondary hypergam in Emory healthcare patients. And we're hoping to visit with you in the next few weeks and months to share some of those findings and work with you to help standardize the practice in various specialties here. Um, just one more slide on quantitative versus qualitative testing. So having, especially in patients who are recovering stages from their heavy immune suppression, having an IgG of 500 or 550 may not be enough to say whether they're protected. So the quantitative may not translate to a functional IgG. So we do look at functional humoral assessment as we talked about in terms of vaccine-specific antibody titers, etc. And so this has been the standard of care in evaluating and managing primary immune deficiency patients, and we feel that should be applied to patients with secondary hypergam also, based on what the guidelines are nowadays. All right, and this is my final slide where we'll talk about process here. So if you take a patient with secondary hypogammaglobulinemia, um, and those who've now recovered on the right side, fairly simple, direct. So those who have no severe infections, IgG level greater than 600, behave just normally. So you can monitor them and follow them. The other extreme on the left, you'll see when they're critically low, below 150, really almost everybody would just go directly to initiating IgG replacement therapy and having them on prophylactic antibiotics. That sort of gray area between where you get severe hypogam below 400, the literature in solid organ transplant and hemonc malignancies has talked about 400 as being a good guide. So below 400, 400 to 600, they do have serious infections. Below 400, we go to IgG replacement. 4 to 600, we look at trial of antibiotic prophylaxis. If there's no benefit, then going to now. It's just guidelines. It's a sort of a collation of what's been written here and in Europe and other countries, but really needs to be individualized to the patient. So the summary, we've introduced screening methodology beyond HIV for adult patients with suspected non-HIV immune deficiency after you've ruled out HIV. I've talked to you about CVID, hoping to give you an idea about recognizing referral to specialists and needing lots of collaboration. And then, of course, the increase in incidence of patients with secondary hypergam due to widespread increasing use of these agents. And we feel there's a great opportunity to standardize monitoring and management protocols at Emory to improve quality of life and decrease adverse outcomes. And we're very happy to work with all of you to look at how that's being done and then maybe work with order sets, etc. Much to be learned, as you've seen. The quality of evidence is not great for some of our guidelines recommendations, though it's very difficult to come by. But I think we need to continue to question and do the best we can. Keep pace with our immune suppressive therapies, look at our local healthcare data, professional societies, and an open plea and an invitation to those who want to learn more about immunology. It's a niche practice area within allergy immunology and definitely within infectious diseases and clinical immunology. And welcome to come spend some time with me or to even just brainstorm how you'd like to get into this field. I'll leave you all with the reflection and acknowledgement. I think in clinical immunology, as in all of medicine, our patients are often our most profound teachers. And over the years, I think their resilience in the face of uncertainty has taught me three essential lessons: to listen with humility and more care. I think that's much more evident, and I think it hits home in the era of chatbots and artificial intelligence. To think with a broader differential diagnosis than we usually do, and then persist with more conviction when the answers are not obvious. As all of you take care of your patients, you've seen this, and I think it's a privilege to serve our patients. So I cannot ever have done this alone. From my mentors who started me off in immunology at the University of Connecticut, Dr. Rajan, and my immunology mentor, Dr. Hill, at the University of Utah School of Medicine, my fellowship faculty mentor, Dr. Seymour, who started me off, and then now my colleagues here at Emory University and the full clinic of adult asthma, allergy, and immunology, from the providers, the nurses, the front office, amazing group of individuals who've welcomed me with open arms. Pulmonary division leadership, Dr. Greg Martin, Tony, Dr. Anyang Lee, who gave me the opportunity to come and practice here at Emory. Our colleagues, Dr. Roback and Warner and others in pathology and lab medicine, who do an amazing job for immunology testing. And all our colleagues in primary care and specialties who I've worked with. We've learned a lot from our Children's Healthcare of Atlanta CHOA colleagues who do an amazing job for their patients and now are graduating adult survivors to my clinic. And of course, I'd love to acknowledge the time I've spent at VA Salt Lake City and most recently at CDC. You would think, amidst all the COVID and emergency responses, informatics surveillance, I still had the opportunity to think through clinical immunology, serology, and vaccinology during those emergency responses. So I'll stop here. Thank you again for this amazing opportunity, and happy to take questions, and I'm happy to take offline also afterwards. Thank you. Handing
Thank
it
you,
back to you,
Dr.
Dr. Messer.
Gundlapalli. Yeah, thank you so much for this really comprehensive review. It's really so interesting to gather some of these insights about patients that we refer and may not know all of that nuance, and how we approach it and manage it. In terms of questions, we have one from Dr. Cartwright. Thank you for this excellent informative presentation. In your patients on sub-Q IG, do most patients self-administer, or is there home health nursing needed to assist with administration?
That's a fantastic question. The home health nurse will teach them over 3 weeks and then they administer themselves. So they learn, usually most of my patients do it by themselves. Some have help from their spouse, parents, etc., and caregivers. Very rarely do we have to get nursing to do unless they're completely bedbound, not able to do. So it's a very good question and a lot of autonomy that the patients have. Happy to discuss more. Thank you.
What other questions do y'all have? Uh, is there a role for tracking these patients longitudinally via the EHR?
Yes, very much. That's actually a very good question. I did want to talk maybe 1 minute about using algorithms to identify patients. So there have been many studies that have looked at patients, mostly for primary immune deficiency, where you look at those that are visiting different specialties in a healthcare system for infections, and then nobody's has yet connected the dots. So yes, so there is use an amazing opportunity to do mining and now, of course, artificial intelligence to look at those patients. And that's how we're looking now with secondary hypogam to look at the journeys of these patients over years, 2 years, to see how they're doing. I have not done that here for my own primary immune deficiency patients, but have done that in Utah to look for longitudinal outcomes. That's how we learn, I think, to be able to put at least partially the evidence base behind our applications. So happy if anyone's interested, fellows, young faculty, please feel free to get in touch with me and we'd love to do that. Thank you.
All right. Otherwise, the chat is just largely a lot of thank yous and excellent presentation. So, and we
Mhm.
are time. So thank you again, Dr. Gundlapalli, for this incredible presentation and the work that you were doing and being our referral center for so many of our very complex patients. And thanks y'all for being here and have a great rest of the afternoon. All right. Bye, y'all.
Bye bye. Thank you.